All right, hi everyone. Welcome to this month's ASC e-journal. My name is Dr. Heather Chen-Yost, and I'm here with my co-authors for this paper, Dr. Rachelle Mendoza and Dr. Anna Biernacka, and we will be talking about this recent study that we published called lung adenocarcinoma with isolated TP53 mutation, a comprehensive clinical, cytopathologic, and molecular characterization. And then I also have Drs. Lee and Heyman who will be here moderating this presentation. We do not have any disclosures to report. Advance. This is myself. I'm currently a pulmonary pathology fellow at the University of Michigan. I was their cytopathology fellow last year, and I'll be joining on as faculty in August. And I'll have Dr. Mendoza and Biernacka introduce themselves.
Hi, so I'll go first. So I'm Rachelle P. Mendoza. I'm currently assistant professor in University of Rochester Medical Center. I met Dr. Biernacka and Dr. Chen-Yost during my fellowship in cytopathology in University of Chicago.
Hello, my name is Anna Biernacka. I am at University of Chicago. I'm cytopathologist and breast pathologist, and I met Rachelle and Heather when they were trainees at U Chicago.
All right, great. Thank you. So the objectives of this talk today is that we're going to discuss these findings that we saw in lung adenocarcinomas with isolated TP53 mutations. We'll go over the general demographics, the cytomorphology, their immunohistochemical or I-Hsuan profile, and molecular patterns. So molecular analysis of non-small cell carcinoma, including adenocarcinomas, have been a key part of workup as of the past couple of years. And this is because we have now really great targeted treatment for common driver mutations such as EGFR, KRAS, and ALK. And this really helps with extending survival times and improving prognoses of these patients. TP53 in general is seen in about 50% of adenocarcinomas. The majority of the mutations are in these hotspot regions, which is usually that DNA binding region in exons 5 through 8. Most of these mutations end up being missense or nonsense mutations, which means that the TP53 has a loss of activity. Previously, this mutation has been associated with high-grade fetal-like morphology in adenocarcinomas, and notably non-small cell lung carcinomas with TP53 mutations are associated with worse survival and poorer response to chemo and radiation. So the aim of our study is to characterize lung adenocarcinomas in particular with isolated TP53 mutations. This is the largest series to date. Previous studies only really analyzed TP53 in settings of other co-mutations. So this one is going to be one of the first that really hones in on just that mutation and without the interference of other lung adenocarcinoma mutations. Oops, sorry. So we collected cases from the time span of January 2016 to January 2021. These all were diagnosed as lung adenocarcinomas on the cytology or surgical pathology, and these were all biopsied via the ultrasound-guided transbronchial needle. That's just part of the standard of workup at University of Chicago. And these were also cases that had molecular studies performed as part of the diagnostic workup. So this was done pre-research collection and not done post-research collection. And the molecular results showed only a pathogenic TP53 alteration. And if it had additional alterations, that didn't qualify for this study. We also collected some demographics, namely age, the sex of the patient, the number of PAC years, the tumor location and laterality, the size of the tumor, the clinical stage at diagnosis, treatment, if the patient had recurrence or metastasis, the patient's status at last follow-up, the risk-free survival in number of months, and also the outcome survival in number of months. We then looked at the smears and analyzed a few cytomorphologic features, such as the background, the architecture, nuclear size, nuclear to cytoplasm ratio, pleomorphism degree, chromatin quality, nuclear membrane contours, and intranuclear inclusions. And then we also, if the patient had a concurrent surgical biopsy or resection, we included that histology. And the original diagnosis was made pre-research collection by pathologists trained in thoracic pathology. We also performed IHCs, either counted the ones that were performed as part of the diagnostic workup or did additional IHC stains. And these IHCs that we performed were TTF1, SAL4, CDX2, CK7, CK20, synaptophysin, chromogranin, P53, and also PDL1. And this was the 22C3 clone, and we used the tumor proportion score as per the manufacturer's instructions. So one question I had for my co-authors was why this IHC panel was selected.
Yes, so we selected this, I think, medium-sized panel, and part of the markers were part of the diagnostic workup, as Heather said, and the other we had specifically for this study. And TTF1 is such an example of a stain that we use very often in our daily practice to further characterize non-small cell carcinoma of the lung, especially if the obvious cytomorphologic features of adenocarcinoma or squamous carcinoma are not present, evident, and we use it in conjunction with P54. As Heather mentioned, there were some observations suggesting that isolated TP53 mutation may be seen in this rare subtype of lung adenocarcinoma that is fetal-like adenocarcinoma, and this type of adenocarcinoma was shown to have an aberrant expression of SAL4 and CDX2. SAL4 being one of the oncocytal proteins, most commonly used as a marker of germ cell tumor, and CDX2 as a commonly used marker of enteric differentiation. So we wanted to see if we had this fetal-like morphology and also a specific fetal-like immunoprofile. We also did some cytokeratins like CK7, CK20 for this most broad distinction of tumors occurring above and below diaphragm. We use synaptophysin and chromogranin as neuroendocrine markers, also to look at the fetal-like differentiation, because interestingly, this fetal-like adenocarcinoma, they do express neuroendocrine markers, and PDL1 we use routinely for all of our lung cases. So we had it as a part of the diagnostic workup, and P53 we used to perform specifically because of the scope of the study to see if tumors with alteration, molecular alteration within P53 aberrant expression of the protein.
Okay, thank you very much. All right. We also performed next generation sequencing, and this was using the University of Chicago Medicine OncoPlus panel, also known as UCM OncoPlus. And this is a hybrid capture panel that targets about 1,005 cancer-associated genes, possibly more now since this paper was published. And so what we used was either a representative diff-quick stain cytology smear or from the formalin-fixed paraffin embedded tumor block. And then the variants were inspected using the Integrative Genomics Viewer program, or also known as IGV. We also looked at copy number results using the CNV kit software. And then to determine the characterization of activity for the P53 mutation, we looked at the International Agency for Research on Cancer TP53 database. So one question I had was, why did we decide to look at the copy number results for this study versus just focusing on the genetic mutations?
Yeah, so that is actually a good question. But the decision to investigate the copy number alterations and also including other non-conventional molecular analytics such as tumor mutational burden and microsatellite instability is based on prior studies and prior investigations on TP53 mutated lung adenocarcinoma and also other TP53 mutated cancers all over the body. It has been associated with increased genomic instability in the form of copy number alterations. And we would like to see if we observe the same phenomena and a correlation in our cohort.
All right, thank you. We also performed RNA sequencing, and this was also done with the University of Chicago's RNA OncoPlus assay. And this is, again, a hybrid captured based sequencing assay, but this targets RNA, and this detects known and novel fusions involving the targeted cancer-associated genes as part of the OncoPlus panel. So this was performed by our statistician, and they used the software, the IBM SPSS version 29, and used these tests in order to find associations within our database. They used a two-sided hypothesis test and then assigned a p-value of less than 0.05 for statistical significance. So our results were that we had about 14 lung adenocarcinomas with sole TP53 mutations that were identified. And this was out of like maybe 844 lung adenocarcinomas in this time period. The average age of these patients was about 65.7 years, so rounding up to 66 years with a range of 48 to 79 years old. Our sex distribution, it was skewed male, so about 9 males and 5 females. All of these patients had a history of smoking and had an average pack year of about 40.7, and this ranged from 10 pack years to 70 pack years. As for the disease presentation, most of these patients presented as stage 4 for their clinical stage. So that was about 5 patients. The other 5 patients that were worked up for clinical stage, 3 of them were staged as 3A, 2 of them were staged as 3B. So for metastasis, and I understand it says all patients, but this is just all the types of different metastasis that were presenting. Some of them had brain metastasis, a few had pleural metastasis or pleural effusions, 4 of them had distant organs, oh that's a typo, and 1 of them had contralateral lung and the other had distant lymph nodes. The average size of the tumor was about 3.7 centimeters, with the range being 1.3 to 8.1 centimeters. For treatment, 10 received treatment, 4 patients declined treatment or expired before treatment could be given. 7 of them received chemotherapy, and this was mostly the standard platinum-based and permexotred chemotherapy. 4 of them received immune checkpoint inhibitors, and that was either pembrolizumab and ipilimumab / nivolumab with chemotherapy. 6 of them received radiotherapy, and 5 of them had surgical resection. 2 of the patients ended up having local recurrence. 1 of them had it 6.2 months post-surgery. The other one had it about 84 months post-surgery, so quite many years down the line. A few of them had distant recurrence. 2 of them had it in the pleural fluid. 1 of them had recurrence in the brain, and 1 of them had recurrence in the peritoneum or omentum. And the progression-free survival was fairly low. It was about 8.4 months, with a range of 0 months, and which reflects the patient who was deceased, to 84.8 months. For the outcome of this, for these cohort, the median overall survival was about a year, so about 12 months, and the range of survival was between 3 months to 101 months. 9 of them ended up dying of the disease. 3 of them are currently alive without disease. one is alive with stable disease, and one patient was lost to follow-up. So now we'll move on to morphology, especially cytomorphology. So in terms of differentiation, most of these cases were poorly differentiated, with only 4 cases showing moderate differentiation. In terms of arrangement of these adenocarcinomas, 7 of them showed that they were arranged in sheets and clusters. 4 of them showed acinar and glandular formation. And in terms of the background, about 11 of them showed mild to moderate chronic inflammation, and 3 showed background necrosis. As Dr. Biernacka had mentioned, TP53 mutations can be associated with fetal lung-like cytomorphology or architecture, but none of the patients in a cohort demonstrated that fetal morphology. So these are the photos of the some of the samples, and so I guess I would like for us to maybe discuss what were the common cytomorphologic features in these cases.
Yeah, exactly. So these are representative images of all the cases with numbers, and as Heather mentioned, like a majority of the cases were poorly differentiated and showed tumor cells in clusters and large sheets that were present in the necro-inflammatory background. Like as an example, like let's look at case number 2, for example, of case number 1, showing these larger clusters. The tumor cells were showing large nuclei with high nuclear to surface ratio. The nuclei were hyperchromatic and the chromatin pattern is in the poorly differentiated tumors was coarse and granular, and the membranes of this nuclei were highly irregular. And the pleomorphic singly dispersed cells were also present. And if you could move to the next slide, like for example, case 13 and 14 show tumors that were in minority that we describe as moderately differentiated. So there was some glandular differentiation seen in cytology smears, and the nuclei in general were smaller. As you can see, they were more regular. The chromatin was fine, evenly distributed with maybe some nucleolysine, and the membrane were also smooth with some nuclear growths. So those we labeled as moderately differentiated.
All right, thank you. So in summary, as Dr. Biernacka had mentioned, most of these cases showed single markedly atypical cells with high end-to-C ratios, these hyperchromatic and large nuclei, moderate to markedly pleomorphism, evenly coarse granular chromatin, irregular nuclear membranes, rare intranuclear inclusions, and abundant mitotic figures. So these are the results of our I-Hsuan studies. So as one can see, the majority, almost all, basically all of them were CK7 positive. For CK20, the majority of them were negative. 3 of them were CK20 positive. For TTF1, about half were positive and half ended up being negative. CDX2, only 2 were positive, and the majority of cases were negative for CDX2. I think only 1 case expressed neuroendocrine markers, the synaptophysin and chromogranin, but the rest of them did not express these neuroendocrine markers. None of our cases expressed SAL4, again, confirming that these were not really that fetal type adenocarcinoma. For the P53, half of them had increased expression and the other half had only shown wild type expression. For PDL1, 9 of them were negative, but in the 5 that showed membranous staining, it was either moderate to strong expression in about 50 to 100% of cells. So these are the results of our molecular analysis. So the NGS was performed on a variety of samples. 8 of them had this performed on a lymph node metastasis, and these were samples that predominantly consisted of the adenocarcinoma versus like adenocarcinoma with lymphocytes mixed in. And 6 of them were performed on the primary lung tumor. The TP53 mutation locations, exons 5 to 8 were the most common locations, confirming what we had discussed in the introduction. That's a common hotspot mutation, and that was about 8 of the patients. So in terms of the types of mutations, 8 of them were missense mutations, 2 of them showed nonsense mutations, 2 of them showed frameshift mutations, and 2 of them showed insertion deletion type mutations. So the effect on the P53 function based on prior predicted databases, 11 of them were predicted to show a loss of function or reduced activity. 1 of them showed a dominant negative P53 function, and 1 of them showed a gain of function, interestingly, which we will discuss later as to why that might be the case. And 1 of the mutations had an unknown effect on how P53 would function. For the tumor mutation burden, the mutational burden was about 11.7 mutations per MB. About 8 of them had low tumor mutation burdens, and 6 of them had high tumor mutation burdens. MSIs were also tested too, and all of them showed MSI stability. So this is a diagram of all the different mutations, and I'll have Dr. Mendoza talk about this diagram.
Well, as had already discussed, this diagram shows the most common location of the mutations found in our cohort. And as you can see here, most of the mutations are within the exon 5 to 8, which is the DNA binding region of the TP53 gene. And they are mostly missense mutations, and there are some other non-missense mutations along that line. Outside the DNA binding gene, there are also mutations seen in the coding region and in the apoptotic response site of the gene.
Thank you. So we'll continue on with discussing the tumor mutation burdens. So for patients that had a missense mutation, the average tumor mutation burden was about 7.3. For the non-missense mutations, the average tumor mutation burden, or TMB, was 13.1. But when we looked at the different types of protein alteration, so if it was truncated, if it was a missense mutation, the average TMB was actually higher than if it was a non-missense mutation. So that would be, the average was 17.4 versus 12.2. When we looked at altered DNA binding protein, missense mutations again had a higher TMB versus non-missense mutations. So the average for the missense mutations was about 8.5, and the average for the non-missense mutations was 5.9. When we looked at copy number variations, this was seen in about 9 of the tumors. There was amplifications in 1 to 11 genes in 8 of these patients. Gene loss was observed in 7, and both amplification and losses was seen in 6. So frequent genes with copy number losses, the most common one was CEBPA, which is located on chromosome 19, and that was 5 of these tumors. 2 of them showed a copy number loss in RAD51, and 2 of them showed copy number loss in DDX41. So we looked at a couple of correlations, and these were our most significant results. So we wanted to see if the overexpression of P53 on IHC was associated with a type of mutation, and there was a correlation between overexpression of P53 on IHC and missense mutations, and that was clinically significant. For tumors with missense mutations in truncated proteins, this was found to be associated with a higher proportion of PD-L1 expression. In terms of like TP53 alterations and tumor mutation burdens, we didn't really find a correlation between the type of alteration and whether or not the TMB was elevated or not. So now we'll move on to the discussion from these results. So we'll discuss a little bit about TP53 in general. It is seen in a high prevalence of small cell carcinomas. About over 90% of these small cells will end up having a TP53 mutation, and also a high proportion of squamous cell carcinomas will have a TP53 mutation, so about 81% of them. In adenocarcinomas, this ranges between 40 to 46% of patients will have a TP53 mutation, and this is increased in likelihood if you are a smoker. That will increase your risk by 3 to 4 times. Zhao et al. Has created a P53 deficiency score that was to help with predicting the recurrence-free survival. And if you have a high score, that correlates with poor survival. So in terms of like the types of mutations on the exons, other studies have analyzed this. So for TP53, a mutation on exon 5 has been correlated with a shorter survival in squamous cell carcinoma. On exon 6, that has been shown to be correlated with poor prognosis and nodal metastasis. And on exon 4, if this is combined with an EGFR mutation, it actually has a good predictive and prognosis indicator. For gain in function, as we noted, there was one adenocarcinoma that showed a gain in function of TP53 in our cohort, which seems a little unusual, but other studies have shown that when you have a gain in function, it can then start interacting with new transcription factors, and it can actually alter things such as transcription, cell cycle, apoptosis, and metabolism, and in general make things more tumorigenic. So essentially, I guess if you have too much function or loss of function, it kind of leads to this like tumor creating process. So the association between TP53 and PD-L1 expression has been documented previously. A missense mutation in TP53 has been correlated to have a better response to immune checkpoint inhibitors. Patients with advanced non-small cell lung carcinoma and TP53 mutations that have been treated with immune checkpoint inhibitors have longer progression-free and overall survival. So these results, I guess, can show that if you have a missense mutation TP53, maybe we can try going ahead with those PD-L1 treatments, despite whether expression is high or not. We'll discuss also CEBPA, as that was the most frequent copy number variation we found in our cohort. This is a gene that is most often associated with AML, and the detection of this mutation has an improved outcome for pediatric and adult AMLs. For lung adenocarcinomas, it is also a frequently observed mutation. When it is functional, it inhibits migration and invasion by suppressing epithelial to mesenchymal transition, and this is based off of basic science studies. A loss of function, because like it inhibits migration, that might explain why the loss of this can lead to aggressive clinical behavior. Which means that essentially the lack of this gene might mean that it is easier for other cells to start going through migration and invasion. So a couple of limitations of the study. So this was a small number of cases, and not all of them had aberrant nuclear P53 IHC expression. There's a couple explanations for this that we thought of. One of them could be that the immunophenotype could be discordant with the genotype that has been observed before in other tumors, such as ovarian carcinoma, as indicated in this paper down below. It could just be the sample bias, and that means in particular the section of that we decided to do this I-Hsuan stain on might just not have shown expression. Tumors also can have had heterogeneous profiles, so maybe the areas that we had selected for I-Hsuan staining could have just been the area that wasn't going to express it, and then had we selected another section, maybe it would have expressed shown an overexpression of P53. It could also just be that there were issues with the suboptimal fixation at the time of processing, and also since some of these patients we ended up staining them well after, maybe a few years after their initial diagnosis, it could just be that the proteins had degraded over time, and so the I-Hsuan expression wasn't going to be as strong as it would have been had we done it up front. So in summary, so for these patients that have lung adenocarcinoma and isolated P53 mutations, we noticed that they were basically all smokers, and most of these had metastasis at presentation, and most of them had died of disease. So a pretty aggressive type of tumor. The cytomorphology was largely poorly differentiated and had high-grade features. For I-Hsuan, half of them were TTF1 positive and had overexpression of P53. And we also noted on NGS that the missense mutations were correlated with P53 I-Hsuan overexpression. The truncated T53 mutations correlated with PDL1 positivity and shorter overall survival. And these types of tumors tend to show frequent recurrent CEBPA copy number variation losses. I guess one question I had was why did we decide to correlate, do these types of correlations for statistics for this study?
Yeah, so TP53 mutation in any tumor setting, along and also commonly in association with other somatic mutations, have been associated with smoking and other poor prognostic factors such as metastasis, recurrence, and shorter overall survival, and even chemotherapy resistance. So we would like to explore whether these same variables can be seen in our cohort, and it's really interesting that we did see the same poor prognostic markers in our patients.
Okay, thank you. So that's the end of our presentation. I was very focused on this paper. So I'd like to thank a couple of people who are part of this presentation. Obviously, my co-presenters / co-authors, Dr. Biernacka and Dr. Mendoza. I'd like to thank Dr. Xingjing for suggesting me to do this presentation. Thank you again for considering me. Dr. Lee and Dr. Heyman for being the moderators of this presentation, and the ASC eJournal committee, especially Joanne Jenkins for organizing everything. So yeah, so that's it. So do you have any questions or comments? Thanks.
At this time, there's no questions in the question bank.
Okay, thank you.
If there's no questions in the chat, I think this paper raises lots of great questions, and I don't want to take everybody's time with a ton of them, but first of all, congratulations on putting it together, a data set like this. This is both on the molecular side and the morphologic side. I think this is just a remarkable data set, which is great for the community of cytopathologists to work with. I'm especially impressed with the images you got of the tumors themselves. Just looking at the paper, they really kind of look ugly, and you describe them as high grade in morphology. And I think we all kind of have a good general sense of what high grade looks like, but in order to identify these in the future, are there any kind of rigorous criteria that we can apply to call things high grade so that maybe we can identify these type of tumors in the future?
This is really great question, because for now we only have validated, established mode of grading in histologic specimens. So histologic grading, which is based on the predominant architectural pattern, and this grading system is the most importantly has prognostic implication. However, there are multiple application processes, like issues with the grading system. First of all, we could only study this histologic grading in stage 1 adenocarcinomas that actually have excision specimens to look at, but in up to like 2/3, I guess, of patients, they present at the stage when they are inoperable. So cytologic specimen is the only tissue, or a small biopsy, cytology or small biopsy is the only tissue that will be available for evaluation. And the need for cytologic grading has been there, and some studies address it. We refer to the study from Memorial. It's a study from Dr. Siegel. This is a retrospective study in which they look at over 100 of cases that stage 1 adenocarcinomas that actually have excision, and go back and pull the specimen of diagnostic FNA. And they look at the various cytologic features against the histologic established on the excision. And since we have some time, I want to remind this histologic grade. So basically, we have 3 grades, and they are based on the predominant histological pattern. Grade 1 will show predominantly lipidic pattern. Grade 2, acinar or papillary, and grade 3, solid and micropapillary. So even from like basis for this staging system, you may see it's really difficult to recapitulate in cytology specimens where the architecture is not well preserved, it's actually disturbed. So when other studies look into cytoarchitecture versus histologic grade, it really didn't show any good results. However, when you think about it, in cytology, the nuclear features are really well preserved, and they were shown to be significant in assigning tumor grade in other organs, like, for example, breast cancer. So, and basically these are the findings of this group, that they show that architecture or background, or either are clusters or like small glands or papillae, they are not really correlating with histologic grade, but what is correlating are nuclear features. And they develop a specific score that includes 3 parameters looking at the nuclear features, and these are nuclear size, the features of the nuclear membrane, and also the pattern of the chromatin. So these are features that we are very familiar in cytology, so this scoring system is relatively easy to apply. So even though in our study, because this was not a focus on the study, this type of correlation, we didn't use this system very rigorously, we definitely refer back to this paper and this system and focus on the high-grade nuclear features, predominantly based on this paper.
Yeah, actually, yes. Thank you for presentation. Very nice work. And, you know, we learn a lot from this subtype of adenocarcinoma from your presentation. I have a really quick question. So for disease, I mean, tumor-free survival, any of them use PD-L1 treatment or targeted? Maybe I missed. Yeah, I saw, yeah, you mean I saw all the patients, oh, only 4 were treated?
Only 4 received treatment that was targeted, yeah, or targeted with PD-L1.
What about this 4 patients? They have a better survival, or did you compare this 4 with the other 10 without checkpoint inhibitor? Did you compare?
Our main limitation was a very small group of patients for survival analysis. So, however, others, and Heather mentioned this study, shown that patients with TP53 mutation had better survival with immunotherapy. But
Okay.
right?
Yeah, thank you. Oh, back to tumor grade. I think current 2023 WHO classification, they propose the grading scheme. That there's a table. There's criteria. Pretty much depends on resected tumor, right? They have architecture. They have cytologic histology features. So one of the, but this is still ongoing work. So International Association Study of Lung Cancer, they also propose this grading system. And also there is some, features, not like breast cancer, the grading system already established. So lung cancer is still ongoing study. And also one of the criteria they didn't include in the grading system for lung cancer is the tumor necrosis. They didn't include that. So maybe, maybe in next, upgrade WHO classification, they may include more established, standardized criteria. Okay, thank you so much.
Yeah.
Thank you.
And there is still no questions in the chat.
Okay, sounds good.
Right, then we thank everybody for joining us today.
Yeah.
We hope to see you next month for the next installment of the e-journal.
Thank you, everyone.
Thank you.
Thank
Bye-bye.
Thank you so much. Thank you.
Thank you so much. Thank you, Rachel. Thank you, Heather.
Thank